Welcome everyone to Grand Rounds today. Overnight was the coldest night on record since 1995 and the coldest February day since 1900 and frozen to death. So, but the weather has not stopped Grand Rounds. We plough on. This is the closest Grand Rounds we have to Valentine's Day, and I try to offer this slot to the cardiologists as a slight nod towards the heart for Valentine's Day. And John Irving, Grand Round stalwart, has stepped forward to give the annual Cardiology Valentine's Day Grand Round. So he's given us the title of What Becomes of the Brokenhearted. I found out yesterday in a fortuitous corridor conversation that he's going to talk to us about a rare cardiological diagnosis, and then he's going to muse on the how to make a rare diagnosis. So John, thank you very much for stepping into the breach as always, and I look forward to hearing what you've got to say about the broken heart.
Okay, thanks, Tom. I hope that the title leads to an effect of elegiac regret rather than callous flippancy. And I'll just press on with the talk. So shortly after Christmas last year, a 71-year-old male from Dundee, generally very healthy, smoked cigarettes, but no significant comorbidities. He'd been reporting several weeks of quite severe right upper arm pain, and had had a telephone consultation with his GP, and they concluded it was musculoskeletal in origin. He was found by his partner collapsed. He'd been doubly incontinent. He was incoherent, but could indicate that he was experiencing severe chest pain. They called the paramedics, and here's the ECG, and people who are unfamiliar with ECGs should recognize that it's very abnormal with very marked ST segment elevation in the anterior leads with reciprocal change in the other leads. He came into coronary care around about 8 o'clock in the morning. He was confused, he was in pain, he was freezing cold. His blood pressure at best was about 53/36. The overnight team on call performed an immediate echocardiogram. The relevant features are that this is the left ventricle here, this is the papillary muscle here. The lateral wall is thickening and moving in. The septum here is thickening and moving in. The apex seems thinned, isn't moving. And on the outside of the apex is this bright echogenic structure. And outside all of that, this dark band is fluid in the pericardium. This is another view from the subcostal view, looking through the liver. Here, there's a lot of fluid on the inferior surface of the heart, and the right ventricle wall has this characteristic buckling. Now, there's a lot of things going on, and the first people that arrived to see him thought that he's had an MI, clearly, but he's probably had a stroke to explain the confusion, and they thought perhaps a CT scan of the brain would be the first best step. But I thought, well, actually, I can tie this all together in a single diagnosis. If we go back up again, he's had a anterior myocardial infarction. He's had myocardial rupture leading to the bleeding into the pericardium, and this is thrombus adherent to the external surface of the heart. We took him to the cath lab. And again, I'll talk you through this video. In the background here, you see lightness or a light appearance coming and going. And that's an intra-aortic balloon pump to help support the blood pressure. This is our catheter that's come in via the right radial artery. This is the left mainstem. This is the LAD. And as expected from the ECG and the echo, there is a severe lesion with poor flow in the distal segment of the LAD. We took one image of the right. You can't see this kind of jerky filling that you get when the end diastolic pressure is very high, and so that there's poor flow down the coronary arteries, but the right coronary artery and the circumflex were unaffected by disease. So I phoned the surgeon in Edinburgh. He said, yes, that sounds like a surgical emergency. We put the patient in the ambulance. We didn't worry about a medical escort because if there was further deterioration, there was nothing that a medical escort could do. They headed off down to Edinburgh at top speed. They went to the surgical ward and were redirected immediately to theatre. And these are the findings of note. There was a large hemopericardium. They found a small apical tear with large hematoma and infarcted apex. They drained about 400 mils of blood. They incised the heart and they stitched a patch, which they describe as parachuting into the left ventricle and patch on the top. He had a moderately stormy course requiring support from 3 different inotropes as well as the balloon pump. He developed shock liver and acute kidney injury that peaked and recovered. He required treatment for ventilator-associated pneumonia. He had a significant drainage from his chest drain. But he went home on day 10, and I've spoken to him on the phone. He's done well. And this could appear to be an everyday miracle of modern cardiology, featuring use of imaging technology and support and working as a team. And it could be an everyday miracle of modern cardiology, but I had never seen this presentation before this day. Now, it's not possibility of myocardial rupture presenting initially in this fashion. I mean, generally, it's fatal. Some case series demonstrate 100% case fatality. But I was aware that this could happen, but I'd never seen it before. None of the consultants in Dundee have seen a patient survive to get to surgery and recover. I'd never become aware of a case when I trained in Edinburgh or in Newcastle or in Nova Scotia. I'd never seen a presentation of this mode of presentation of myocardial rupture at a grand round or at a learned society. So how do we recognize what we've never seen before? So I'll give you an overview of pathophysiology, but I'll talk a bit more about the previous encounters I've had with myocardial rupture, which were all unsuccessful, but that led to increasing awareness of the possibility. We're encouraged to think about horses when we hear hoofbeats, but hoofbeats can mean zebras, and trying to do that accurately is not straightforward, and I'll talk a little bit about that. So here is William Harvey. The first description of myocardial rupture was of somebody that I think he was acquainted with, who was getting bouts of chest pain. He had an atypical presentation, so he was getting bouts of chest pain. He became cahectic and dropsical, so he had heart failure, according to Harvey. But during one of his paroxysms of pain, he died. He had a post-mortem, and they found that although the substance of the left ventricle had seemed pretty thick and strong, had been ruptured and perforated with a large opening sufficient to admit a man's finger. Here's a post-mortem specimen showing a thick left ventricle. There is probably left ventricular hypertrophy here. There's the pale infarct, and there's the hemorrhagic area where the rupture has occurred, where the plane of blood has torn through the infarcted material, weakened by the infarct, and out to the pericardium. This is a video that I found on my Instagram feed from the New England Journal of Medicine, from a hospital in Norway. There are 2 catheters on this, one here sitting in the left ventricle, one here sitting in the pericardium, draining the pericardium. And you can see when the contrast is injected that there is a serpiginous pathway through the left ventricular wall, and then the contrast collects in the pericardium. Now, how common is this? It used to be really quite common that the original papers, or papers from mid 20th century would report up to 8 to 10% of patients experiencing myocardial infarction would die as a result of myocardial rupture. This is an interesting paper from a large center in Osaka, showing that the incidence of cardiac rupture has declined. And they divided it into areas of treatment of myocardial infarction where there was very little thrombolysis before the publication of ISIS-2 in 1988. That in the 90s, in Japan, there was a mixture of fibrinolysis and primary angioplasty. And in the 2000s, primary angioplasty became dominant. And as we get better at devising systems for accurate diagnosis of myocardial infarction and immediate reperfusion, the incidence of cardiac rupture decreases. There are some risk factors for this phenomenon. Female is a risk factor. Often it's the first manifestation of ischemic heart disease. They have the first myocardial infarction. Often it's a lateral MI, and it can be a very small branch that has occluded that leads to infarction. Hypertension is a risk factor, and patients who've not been reperfused. And these days, that's almost always because they've presented too late. They've presented more than a day after the onset of the severe pain, and we may have even done a cardiologist, but we've elected not to reperfuse them because it's too late for there to be benefit. It's reported in a retrospective series of cases written up by pathologists that most patients have some symptoms beforehand, that they may report pericarditis, frequent vomiting later on, and agitation are the features that were reported to be more common in patients experiencing rupture, and that these may occur for a day or two preceding the sudden hemodynamic collapse. We know that the speed with which the occlusion in the coronary artery develops is key in terms of protecting. And this next video shows a patient who had occluded all three coronaries with minimal effect on the function of the left ventricle and minimal scarring. So this is an image of the right coronary artery that fills through these epicardial collaterals, the left anterior descending, which then fills through these septal collaterals, the distal right coronary artery, and poking in between is a major branch of the circumflex. And we were able to revascularize this patient after an initial stabilization, and he's done very well, despite the fact that he initially had all three coronaries occluded. When myocardial rupture occurs, patients very quickly develop tamponade. And just to remind you that this occurs when there's increased pericardial pressure, leading to decreased venous return, decreased cardiac output, and often very low blood pressure and shock. But in rupture, this also leads to the increased pericardial pressure can lead to decreased bleeding, pericardial clot formation, and stabilization. Intra-aortic balloon pump counterpulsation is going out of fashion for myocardial infarction because a lot of the randomized studies have been disappointing, but they don't include mechanical complications, where there probably is a really quite significant role. And certainly the patient, as soon as the balloon pump went in, started feeling better. He started perfusing his brain better. And this is because when in diastole, when the heart and the aortic valve is closed, the heart's filling with blood again, the machine inflates this balloon that's sitting in the aorta, full of helium, which is inert if there's a leak, and that helps push blood up the carotid arteries, the subclavian artery, down the coronary arteries, and push blood distally. And then during systole, when the heart pumps, the balloon is deflated, and it inflates and deflates very rapidly. And I'll show you that. This is a normal intra-aortic pressure trace. You remember, there's the systolic peak, diacrotic notch of aortic valve closure, that the balloon pump recognizes either through the pressure trace or from the ECG, and times the inflation of the balloon, which raises the pressure in the aorta. The balloon deflates and lowers the pressure. So the effect is actually a lowering of systolic and diastolic pressure from what the heart produces, whilst raising the mean arterial pressure, because the mean arterial pressure is enhanced by the balloon pump inflation. And for the left ventricle, this is very favorable for myocardial rupture. There's reduced systolic pressure and diastolic pressure, reduced volume, and reduced wall tension, so that there's likely to be less bleeding. Now, there is never going to be a randomized controlled trial of balloon pumping versus relief of tamponade by pericardiocentesis. There will never be enough cases to organize a trial of it, and you can argue which is going to be the more effective method of support. So that's what we did. These are the prior encounters that I had during my training, where the patients had experienced, or the patients developed cardiac rupture, and didn't necessarily die immediately. This was the Eastern General Hospital in Edinburgh. It's now been demolished. In 1997, I was an SHO3 in this hospital. I had my membership. I had 6 months of cardiology experience. I had more experience working in remote setting in New Zealand in cardiology, and then again in Edinburgh. So I knew what I was doing. The patient was in his late 60s. He developed a lateral STEMI on the Friday and became unwell on the Sunday when I was on call. He'd been thrombolized with his initial presentation. And he had odd pain, and there was subtle ST elevation. It wasn't the same as the ECG changes of his initial presentation. And the quality of the pain was not like he was reinfarcting. And it wasn't pericarditic. He was just kind of sore. And he looked concerned. He wasn't well. GTN didn't help. And I didn't really know why he was sore. And I gave him some morphine, which made him feel better. And later on, I had a discussion with the physician on call, who was a respiratory specialist, and we all thought that was reasonable. There was no access to echocardiography out of hours in the Eastern General, and the patient died the next day. And well, he died of myocardial infarction. We didn't really conclude what the diagnosis was. I discussed it with a cardiologist of my acquaintance, and he said, "Oh well, that'll be a subacute rupture, but there's nothing you can do. They all die." And that was reassuring to some extent of that the clinical encounter had been reasonable. But I felt slightly let down by the fact that I'd done what I needed to do. I'd learned the curriculum. I'd quite a lot of experience, but I'd not been exposed to the possibility that myocardial rupture could present with subacute symptoms. And then the next year, I was a research fellow, and I was in the library looking for a paper about something completely different, and I found this paper from Chest in 1991, and it reported a case series of 4 patients and how they presented, and 2 of the 4 had survived surgery and had done well. And I thought, well, yeah, that's maybe something that's something I should file away, because maybe there will be patients that we can diagnose and send for surgery. Case 2, this is the RVI in Newcastle. I was, by this time, a cardiology registrar. I'd been working as a registrar for 5 years, so I knew how it all worked. Again, a male patient, fitting well beforehand, mid-60s. He had a non-STEMI. He'd had some ECG changes, but he was pain-free. He was comfortable, and his ECG had improved. I can't remember why I did an echo, but I used the handheld echo that we had then, which showed a small pericardial effusion. There was no RV collapse. He was not in tamponade. He was well. Well, I knew what to do. You put him in a bed, and in due course, it'll be his turn to go across and have an angiogram in the Freeman Hospital. And he died the next day and had a post-mortem, which showed myocardial rupture. And we presented the case at the unit meeting and discussed some of the case series, surgical case series. But there was probably 100 years of clinical cardiology expertise present in that room, and nobody had a case to report where a patient had successfully been identified as having rupture and gone to surgery. Case 3, July 2008. So by this time, I've been a consultant for 20 months. I've done at least 1,400 angioplasties in my career. So I knew that I knew what I knew, and I knew that I knew a lot about angioplasty. The patient presented with what appeared to be a non-STEMI and was having a diagnostic angiogram performed by a different colleague. And the patient had very severe pain, was calling out in pain, which is unusually severe. And they had profound anterior segment depression of about 10 millimeters on the ECG during the diagnostic angiogram. And that's highly unusual. And there was no apparent complication. There was no dissection. There was no air embolus. But the patient was pretty unwell. And they had quite severe coronary disease. They had 3 vessel coronary disease, which I'll demonstrate to you. There's a long segment of tight disease, and it's absolutely critical at this point here. It's very severe in the LAD. The circumflex has occluded here. There's a little bit of collateral filling, just filling the very distal part of the vessel here, but not filling the territory all the way back. And there's a long segment of severe disease in the right coronary artery. But the patient was in pain at that time. There's not somebody that we would send for coronary bypass surgery immediately. We did an immediate angioplasty to the LAD, and the patient felt much better. And the pain resolved completely. And I saw him again an hour later, and he was better, and we could allow him to recover from his MI and think about surgery later. But he died overnight, and he had a post-mortem which showed myocardial rupture. Case 4 was a few years later. The patient was female and in her 50s, normally very well. And she presented with an inferior STEMI simultaneously with another patient who presented with an anterior STEMI. And our practice at that time, and to some extent continuing, was to give immediate thrombolysis from the paramedics. And she arrived in ECG clinically very well, with an improved ECG, and apparent that we would have called reperfusion. The history was clarified that she'd been at a funeral at the graveyard where her mother was buried on the anniversary of her mother's death, and that raises the possibility that actually the ST elevation was as a result of Takotsubo cardiomyopathy and would have improved anyway without the thrombolysis. And that we wonder whether if she hadn't had thrombolysis, perhaps she wouldn't have had myocardial rupture. And because she'd been so well, we tried for a long time to drain the very large effusion. There were 2 pericardial drains and freely draining blood back, but we could never obtain a return of circulation. I don't think there were any opportunities to change the outcomes for these patients once events had started. And my main reflection on these cases is that my current practice is enormously privileged. That when we're called to an emergency, that single patient is the focus of our attention. We have the resources of a cath lab. We have immediately available very high quality echocardiography. We can see tremendous detail of the heart. And there's a lot of experienced colleagues around to talk to with good working relationships. We can say, I'm not sure about what's happening here. We can talk it through and get to the right diagnosis. So I'd like to think that actually I'd have a good opportunity for spotting it again, should such a rare presentation occur. 3 weeks later, middle-aged female patient who never goes to the GP, is a smoker, had been unwell for a few days, reporting a painful left shoulder, bouts of diarrhea, a cold, and painful left foot. Daughter phones, no reply, goes round and finds her in an extremely unwell state, phones 999. Presents to ED, profoundly unwell, very hypotensive, very cold peripheries, especially her left foot. The blood gases are done, bloods are done, she's acidotic, and a CT is requested with a first diagnosis of ruptured abdominal aortic aneurysm. This is the ECG. There are no specific ST segment abnormalities, patients in sinus rhythm, not particularly tachycardic. There is a dominant R wave in these leads, but often these ECGs are done in a hurry, and you can't always assume that the leads are in the correct position. This is the CT scan, and there's a pericardial effusion that's actually quite big. Amongst a lot of other findings, there was a long, detailed report which, in summary, showed a pericardial effusion, possibly secondary to infection or hemopericardium. There was occlusion of the left popliteal artery, accounting for the poor circulation in the left foot. There was dependent ground glass opacification of the lungs. There was air embolism in the veins of the anterior thorax. There was also clot in the inferior mesenteric artery, which reconstituted by collaterals. And one of our registrars was called in and performed immediate echocardiography. You can see the left ventricle here. You can see not bad left ventricular function. You can see a smaller pericardial effusion, and there's a hint of a brighter parts of the pericardial effusion. You can also see that the right ventricle is quite well expanded, and the patient's not in tamponade. The working diagnosis was sepsis, probably from the pericardium. And pericardial sepsis, we know, has a very poor prognosis. Patient was supported with inotropes following a fluid challenge, remained anuric overnight, persistent acidosis, deteriorating liver function. And I came in to do the ward round at about 8 o'clock to be greeted by one of the medical registrars with a repeat ECG. This ECG, I thought, was an ECG in two halves. So if you look at the left-hand side, there is ST segment elevation in lead 1, AVL, but also lead 2, and there is PR depression in these leads. And this pattern of ST segment and PR segment shift is pathognomic of pericarditis. If you look at the chest leads, again, there's a dominant R wave in V1, V2, V3, but there's also ST segment depression, and that looks very suggestive of acute posterior MI. But we often do see ST segment changes in these sort of leads when a patient's profoundly unwell, and we've seen these in the presence of normal coronary arteries with profound, when a patient has profound metabolic abnormalities. So I didn't think it was pathognomic, but I quickly finished up the ward round and went to see the patient in medical HG. And we arranged for, well, I thought we should do pericardiocentesis, because that was quite likely to help the hemodynamics. The echo findings of tamponade are not always reliable. It might help with sepsis control. It might help with identification of the organism. It might also demonstrate cancer. Now, we didn't see a clear cancer on the chest X-ray, but somebody who never goes to see their GP might well present late with a malignancy, and that was the other reason I thought that why she might be quite so unwell. Pericardiocentesis is much better done in the cath lab than just in CCU, because it allows you to take X-ray images that show you when your wire is tracking underneath the diaphragm. So you don't then follow that with the drain. You reposition, and you see it wrapping around the heart. That's very characteristic. And then you can put the drain in with high confidence that you're in the pericardial space. There is the patient also had some coronary disease. That's the right coronary artery. The LED was okay, but in this case, the circumflex, in this view, the circumflex was occluded. So the ECG was now telling us the correct diagnosis, and this is the pericardial drain. The relief of the fluid drain from the pericardium was dark stain, blood stained, and I thought, well, she has cancer. And you've been watching this case presentation. You've heard me talk about myocardial rupture, so I think you're probably miles ahead of me. But it wasn't until the samples clotted that the penny dropped that this was a second case of myocardial rupture within a month. It was referred to Edinburgh. Very extensive myocardial infarction requiring 3 separate patches to successfully repair. And in the same theatre, the patient underwent amputation of the left leg because this was no longer viable. But unfortunately, the surgery was not successful at correcting the acidosis, the coagulopathy, and she died within 24 hours of surgery. My reflections are that I think she had been ill for a while, and I think even if we got straight to the diagnosis, I think the chance of a successful outcome was less likely, but it was worth pursuing. But in terms of getting the diagnosis right, we're trained to rely on the history, but the history was secondhand. It came from the daughter, and if we're not able to interrogate the patient and fill in the gaps and get a better feel for what the cardinal features were, then we will not necessarily hear what the most important part of the feature was. And then when it came to putting it together, we didn't consider the possibilities based on the most unusual feature of the CT scan. Yes, there was a lot going on. And yes, it wasn't certain, but hemopericardium is unusual, and that has to come from somewhere. And it didn't come from the aorta because there was no dissection on the aorta, and it didn't come from the coronary arteries because that's generally as a result of what we've been doing. So she'd not been assaulted, so it has to come from the heart. Now I had to Google what HU was, what these are Hounslow units, which tells us actually is reasonably reliable at saying what the tissue is. And yes, it wasn't at a level where it was definitely hemopericardium, but when you look at the post-contrast images, you can see that the lateral aspect of the heart here, which is, there's the left ventricular cavity, this is the left ventricle sliced through like a donut. In the lateral cavity, you can see wall edema, and that's you can see the myocardial infarction on the CT scan, as well as the pericardial effusion around the outside. Now, 2 cases in 3 weeks. There must be something else going on, and yes, of course, COVID is causing trouble. So this is a paper from this year looking at death rates during the first peak. So death in the excess of daily deaths in England and Wales peaks here in early April. The COVID peak is slightly delayed, but there's an adjacent peak slightly earlier of non-COVID fatalities. Cardiovascular deaths at home have gone up. really quite markedly. Cardiovascular deaths in hospital have gone down because people are not presenting to hospital with their myocardial infarction because they're concerned that they'll get COVID and die. So when we hear hoofbeats, how do we identify zebras? So this is a review paper from American Journal on Family Practice, and it had some principles. I mean, this stated is not immediately helpful. Common diseases are common, rare diseases are rare. Yeah, thanks. But they expand on it, and it is quite helpful. You have to recognize the distinguishing features, those that truly make the likelihood of a rare disease higher or lower, and not just be triggered by things that might make us think of a rare disease. So the one that they quote is night sweats, making us think of TB, and that should be a rare combination of circumstances. Night sweats is rarely TB. They say that the mind is an imperfect likelihood estimator, and that one should be aware of a recent experience dominating one's thoughts. So that didn't actually help us with the initial diagnosis of myocardial rupture. But I would agree that the mind is an imperfect likelihood estimator, and if we don't have a huge amount of experience, we don't know, again, what features to give a prominence to and what not to. They also say that not everything we're taught is correct, and I'm very aware that almost everybody, I mean, the likelihood is that everybody who listens to this talk will never encounter a patient experiencing myocardial rupture, and actually most of you, I hope, will forget all of the features, but will perhaps reflect instead on what matters to them in their specialty, and what they've learned, and the way that they think about somebody who's critically ill. And you know, most people who are confused and have a bit of low blood pressure in this hospital will be treated with broad spectrum potent antibiotics, and that will help that very small number of patients who have sepsis that's responsive to those treatments. But if our thinking is dominated by the fact that we're going to be audited on whether we've achieved sepsis 6 in the decreed time, then we'll not necessarily think further about achieving a diagnosis of a rare and potentially rapidly lethal and potentially treatable condition. So what does the cardiology curriculum say? Well, that the trainee should be able to recognize and manage acute conditions, including this list. And there we are, cardiac rupture. This list is not organized in terms of frequency of presentation, but to fulfill our duty to the curriculum, we should be able to have some case-based discussions, some mini-CACs, and a multiple consultant review of our performance. And that doesn't really help if, you know, none of the consultants have seen the condition in question. So how do we do better? These are my conclusions. Well, we share stories. I'm a fan of the old school grand round with quotes from physicians from 100 years ago. I'm pleased to report that Dr. Bader has organized a joint meeting between radiology and cardiology that should occur regularly, and we will share cases and we will learn better to speak each other's language, so that if there's hemopericardium, well, we need to interrogate the CT for those specific causes because they are few, and we may be able to diagnose it better. And Teams, I have to say, is one really good thing that's come out of COVID. We have regular meetings with the surgeons in Edinburgh and Aberdeen, and the technology works extremely well. And we have minuted discussions about cases and whether they should have PCI or CABG. Twitter is not a total waste of time. There is quite a lot of chaff with only a small few grains of wheat there. But we had another case where we had a great difficulty getting a drain into a patient who had malignant pericardial effusion for the second time. And once succeeded, I was driving home and remembered a case I'd seen on Twitter where they did a balloon treatment to the pericardium, and that was suitable. And it works well when the cases have references, and when it's not just people boasting about like some of the complicated cases they've done. So Twitter, not a total waste of time. And I think that the curriculum for rare but important presentations has to be better. There have to be multiple stories, because you can't just teach the overview. You have to teach the pitfalls. You have to teach the occasions when a zebra is going to look like a horse, because that's going to happen. And what I don't have an answer to is how to reproduce the resonance that you get, the learning experience that you get when you feel, whether it's justified or not, whether it would have changed the outcome or not, but something got past me that I might have stopped, and that for me has been the greatest spur to learning. And if we could reproduce that on a regular basis before we engaged with the curriculum, then that might speed the development of the experienced mind in the trainee. So thank you for your attention. There's time for plenty of questions. Should there be anything that's not clear about it?
Sean, thanks very much. That's really very interesting and very reminiscent, as you say, of the old school grand round presentation and the musings of the grey-haired expert. And I think brave of you to go through the cases where, as you said, you felt that something has slipped past you. Those gnaw at us, don't they? I think we all have those feelings that we've done something wrong or performed poorly when something slips past us. And so thanks so much for sharing them. And I'm pleased that that one was successful finally. That's great. Does anyone in the audience have any questions? Either just, I think you can put your hand up now on Zoom if you've got the most recent update, or you can just turn your microphone on and just start asking questions. Or type it into the chat box as the alternative if you're shy.
What I would say is I don't feel brave sharing those cases because I really don't think that there was an opportunity. The systems were not set up for the prompt identification of what had happened, nor the prompt transfer to a surgical centre, nor the hemodynamic support necessary to maintain the patient so that they could get to surgery. But they did, they did not just slip past. They did leave waves, because we do like to know what's going on. And I think one advantage of getting older is that you know what's going on. You truly know what's going on most of the time, and there's a lot less. Well, I'm not quite sure, but it's probably going to be okay. And so when something doesn't hang together, it really sticks out much more. I've had a bit of an annus mirabilis this year, because not only have I diagnosed 2 myocardial ruptures, I've diagnosed platypnea orthodeoxia, which I've never seen before. And I also spotted a dissection that had got past a few people as well. So, you know, I'm not the kind of guy to keep that to myself. Not because I want to say how wonderful I am, although, you know, I do have to remind myself of that on the occasions when things have slipped past me. I think it is important to remember the triumphs and be able to refer to them, because we all experience the opposite of triumph.
I think there is this. You have to remember that you can only diagnose the rare thing if it comes across you. I think is what you're trying to say. Is, you know, that being vigilant to the platypnea orthodeoxia. Well, that's great unless you see one, you can't make the diagnosis, and clearly you did that this year, and these 2 diagnoses now. I think that talking about you know, the interaction with the radiology is really, really important. It's something that we've done in respiratory medicine. Perhaps we're a lot more radiology heavy than you are in cardiology, with CTs of chest, etc., being so important. So the Hounsfield unit trick is any of the respiratory team or registrars on the call are very familiar with my Hounsfieldometer of what is that in that pleural space. Is it blood? Is it fat? Is it fluid? Is it whatever it is? And that's really, really helpful. And I think you highlighted that you could, a Hounsfield unit of 55 is pretty solid. So that's clot, yeah. or it's a tumor. Yeah. So I think that's very interesting. I think context is king as well. I totally agree with you. If you have night sweats, TB should not be the first thing on your list of diagnoses, but there are some contexts in which perhaps it would be the first thing on your list. Ik is saying, great talk, thanks for sharing. Some of us remember the early days of thrombolysis and saw a few ruptures, 100% fatal in his experience. That maybe drags me on to, you said that thrombolysis in the community, but paramedic delivered thrombolysis, I remember that being a big thing. Are you still doing that? Is that still a thing?
Yeah, good question. The paramedics have reduced the number of thrombolysis doses that they purchase, and in Tayside we have the privilege of the fact that just about everybody lives close enough that primary angioplasty is going to be better for them than thrombolysis. And while when we started, we kind of worried about minutes, and so we set it up so that we give thrombolysis, and we try and determine who had the best potential benefit of thrombolysis. So younger, shorter onset, and further away from the cath lab. We've since moved away from that because we do have the modular lab, and certainly in ours we have the possibility of raising a second team and doing simultaneous PCIs. And actually, for most patients, the hazards of waiting for an additional half hour whilst in a coronary care unit for us to finish the first primary are probably less than the hazards of thrombolysis when you add, a 1% risk of hemorrhagic stroke and then an uncertain risk of myocardial rupture.
Absolutely. Great, thanks. So I think we'll draw things to a close unless anybody has a hand up or has a question. I can't see anybody on my screen. Just checking. No one. Okay. So thanks again for stepping into the breach for the Valentine's Day special. I appreciate it. And a really, really great talk. I think it highlights that the case presentation and then discussion afterwards is a popular talk. We've got over 50 people in the audience today. This is the old style talks we used to do. So if you're sat there thinking you've got a very interesting special talk that you would, cases that, or a run of cases, or a rare case you've seen, or just an interesting case that you could want to talk about, then please do get in touch. The program is full until May, but we're empty all the way from May onwards. So please get in touch and let me know. And as Wendy has said here, great talk, relevant to all specialities. the heart is a great organ. It separates the two lungs and keeps them apart. It's a useful function. And but the talks I find interesting are are things that are below the diaphragm and above the larynx. That outside my own specialist interest, they're always fascinating, I think. So please get in touch. If you're thinking your talk is too niche, it really won't be. It'll be really interesting to the general audience. Okay, thanks very much, everyone, particularly John, and we'll see you again next week for the first of our LGBT+ talks. Thanks very much.